The gastrointestinal system is a continuous muscular tube that begins at the mouth and ends at the anus, gums to bum. Its primary functions are ingestion, digestion, absorption, and elimination. The organs of this system include the mouth, pharynx, esophagus, stomach, small intestine, large intestine, rectum, and anus. Together, these organs form what is called the alimentary canal. Food enters the mouth, where mechanical digestion begins with chewing and chemical digestion begins with saliva. It then travels through the pharynx and esophagus by peristalsis, which is a coordinated, wave-like muscle contraction that propels food forward. The gastroesophageal sphincter, also called the cardiac sphincter or lower esophageal sphincter, controls the opening between the esophagus and the stomach. Its main role is to prevent gastric contents from refluxing back into the esophagus. When the sphincter weakens or relaxes inappropriately, patients may experience gastroesophageal reflux disease. The stomach lies in the upper left quadrant of the abdominal cavity. It serves as a reservoir for food, mechanically churns food contents with gastric acid and digestive enzymes to form chyme. In the stomach, protein digestion begins through the action of hydrochloric acid and pepsin. The pyloric sphincter regulates the controlled release of the partially digested food, or chyme, into the small intestine. The small intestine is approximately 6 meters long and is divided into 3 sections: the duodenum, jejunum, and ileum. Most digestion and nutrient absorption occur here. The duodenum receives bile from the liver and gallbladder and digestive enzymes from the pancreas. The ileocecal valve, located between the ileum and the large intestine, prevents backflow of contents from the colon into the small intestine. The large intestine measures approximately 1.5 meters in length and includes the cecum, colon, rectum, and anal canal. The colon is further divided into ascending, transverse, descending, and sigmoid portions. Its primary functions are water and electrolyte absorption and stool formation. The appendix is attached to the cecum. While traditionally described as having no digestive function, current research suggests it may have a minor role in immune function and maintaining gut flora, although it is not essential for survival. The walls of the digestive tract consist of 4 layers. The innermost layer is the mucosa, responsible for secretion and absorption. The submucosa contains blood vessels, nerves, and connective tissue. The muscular layer, also called the muscularis externa, enables peristalsis and segmentation. The outermost layer is the serosa, which reduces friction as organs move within the abdominal cavity. The peritoneum is a serous membrane that lines the abdominal cavity and covers many abdominal organs. The parietal peritoneum lines the abdominal wall, and the visceral peritoneum covers the organs. It encloses the intestines, stomach, liver, and spleen, and partially encloses the uterus and uterine tubes. This membrane helps support organs and provides a pathway for blood vessels and nerves. The gastrointestinal system is carefully regulated by both the nervous system and the endocrine system to ensure proper digestion and absorption. The intestine is lined with specialized receptors that detect stretch, chemical composition, and the presence of nutrients. These receptors send signals that help coordinate digestive activity. This regulation allows the body to respond appropriately when food enters the stomach or small intestine. One major control system is the enteric nervous system, often referred to as the brain of the gut. It is embedded within the walls of the gastrointestinal tract and functions independently, although it also communicates with the central nervous system. The parasympathetic nervous system stimulates digestive activity by increasing motility and secretion, while the sympathetic nervous system slows digestion during stress by reducing blood flow and decreasing peristalsis. In addition to neural control, the endocrine system plays a major role. Cells within the stomach and small intestine release hormones such as gastrin, secretin, Cre, Tn, and cholecystokinin/Co, Lu, Si, Stu, Chi, Nohan. Gastrin stimulates gastric acid secretion. Secretin promotes bicarbonate release from the pancreas to neutralize acid in the small intestine. Cholecystokinin stimulates the gallbladder to release bile and the pancreas to secrete digestive enzymes. These hormones ensure that digestion occurs efficiently and at the correct time. Peristalsis is the coordinated wave-like contraction of the muscularis externa that propels food forward through the gastrointestinal tract. This movement is triggered by stretch receptors when food enters a segment of the intestine. If peristalsis slows, patients may experience constipation. If it increases excessively, diarrhea may occur. Medications such as opioids can decrease peristalsis, while certain infections or inflammatory conditions may increase it. The gastrointestinal system includes both the alimentary canal, which is the direct passageway for food we discussed on the previous slide, and accessory organs that support digestion. Accessory organs are structures that assist digestion, but are not part of the direct passageway of food. The accessory organs include the liver, gallbladder, and pancreas. The liver is the largest internal organ and performs over 500 vital functions. It is a large reddish-brown organ located in the upper right quadrant of the abdominal cavity, just beneath the diaphragm and protected by the rib cage. In digestion, the liver produces bile, which helps emulsify fats so they can be absorbed in the small intestine. The liver also plays a major role in metabolism, detoxification, protein synthesis, clotting factor production, and storage of glycogen and vitamins. The portal vein, more specifically called the hepatic portal vein, transports nutrient-rich venous blood from the small intestine and portions of the large intestine, stomach, pancreas, and spleen to the liver. This allows the liver to process nutrients and detoxify substances before they enter systemic circulation. This pathway is clinically important because conditions such as cirrhosis can increase portal pressure, leading to portal hypertension and complications such as varices and ascites. We will learn more about these conditions when we talk about GI disorders in the coming chapters. The gallbladder is a small pear-shaped sac attached to the inferior surface of the liver. Its primary function is to store and concentrate bile produced by the liver. When fatty food enters the small intestine, the gallbladder contracts and releases bile into the duodenum. If bile flow is obstructed, patients may develop right upper quadrant pain, jaundice, or clay-colored stools. The pancreas is an elongated flat organ located posterior to the stomach. It has both endocrine and exocrine functions. As part of its exocrine role in digestion, the pancreatic duct joins the common bile duct before entering the duodenum, where digestive enzymes such as amylase, lipase, and proteases are released to break down carbohydrates, fats, and proteins. The endocrine function of the pancreas includes secretion of insulin and glucagon to regulate blood glucose levels. We will cover the endocrine function more later in the endocrine chapters. With advancing age, predictable physiological changes occur throughout the gastrointestinal system. Swallowing muscles may become weaker and less coordinated. This can result in food being retained in the oral cavity, particularly in the cheek pockets or in the pharynx. Retained food increases the risk for choking and aspiration. The lower esophageal sphincter may lose tone and become less efficient at opening and closing. As a result, older adults are more prone to gastroesophageal reflux. When reflux occurs in combination with weakened swallowing or decreased gag reflex, the risk for aspiration increases. Aspiration pneumonia remains a significant cause of morbidity in older patients, especially those with neurologic impairment or limited mobility. Taste bud atrophy is another common change. Older adults may have difficulty distinguishing flavors, especially salty and sweet. This can reduce appetite and lead to decreased oral intake. Some patients may overuse salt or sugar to compensate, which can negatively affect blood pressure or glucose control. Weight monitoring and nutritional assessment are therefore important components of geriatric care. With advanced age, parietal cells in the stomach may decrease secretion of hydrochloric acid. Intrinsic factor secretion may also decline. Because intrinsic factor is required for vitamin B12 absorption in the ileum, deficiency can lead to pernicious anemia. Vitamin B12 deficiency may present with fatigue, pallor, neuropathy, and cognitive changes. Although the slide references age 70, these changes can vary among individuals and may not occur strictly at that age threshold. In the small intestine, mucosal absorption may become less efficient. While this decline is usually modest, it can contribute to nutritional deficiencies in patients with poor intake. In the large intestine, diminished motility is common. Slower peristalsis increases the likelihood of constipation, which may be compounded by decreased fluid intake, reduced activity, and medications such as opioids or anticholinergics. Encouraging hydration, mobility, and appropriate fiber intake is essential. Aging also affects the accessory organs. Gallstone incidence increases in older adults. This may be related to increased cholesterol concentration in bile, decreased gallbladder motility, dietary patterns, and relative dehydration. Gallstones can lead to cholecystitis or obstruction of the bile duct. Pancreatic function may also decline slightly with age. Secretion of lipase may decrease, which can impair fat digestion and absorption. In some older adults, this contributes to weight loss or a depressed nutritional state. However, significant pancreatic insufficiency is more commonly associated with disease rather than normal aging. Overall, aging affects swallowing, gastric secretion, nutrient absorption, motility, and accessory organ function. Health promotion focuses on modifiable risk factors that support long-term gastrointestinal health. Maintaining a healthy weight, eating a balanced diet with fruits, vegetables, and fiber, limiting processed meats and sugary beverages, and staying physically active can lower colon cancer risk. Limiting alcohol and avoiding smoking are also important preventive strategies. In addition, certain treatments and conditions can cause gastrointestinal problems. Diagnostic testing of the gastrointestinal system includes radiologic studies, endoscopic procedures, nuclear scans, ultrasound imaging, and tissue biopsies. As LPNs, understanding the purpose of each test and associated nursing responsibilities is essential for safe patient care. Radiologic studies such as the upper gastrointestinal series and barium enema use contrast material and fluoroscopy to visualize structures. In an upper gastrointestinal series, the patient drinks contrast, typically barium, and images are taken to identify ulcers, obstruction, or tumors. Patients are kept nothing by mouth for several hours prior to testing. After the procedure, fluids and sometimes laxatives are encouraged to prevent impaction from retained contrast. Stools may appear light or chalky for several days. Diagnostic testing of the gastrointestinal system includes radiologic studies, endoscopic procedures, nuclear scans, ultrasound imaging, and tissue biopsies. As LPNs, understanding the purpose of each test and associated nursing responsibilities is essential for safe patient care. Radiologic studies such as the upper gastrointestinal series and barium enema use contrast material and fluoroscopy to visualize structures. In an upper gastrointestinal series, the patient drinks contrast, typically barium, and images are taken to identify ulcers, obstruction, or tumors. Patients are kept nothing by mouth for several hours prior to testing. After the procedure, fluids and sometimes laxatives are encouraged to prevent impaction from retained contrast. Stools may appear light or chalky for several days. A barium enema evaluates the lower gastrointestinal tract. Contrast is instilled rectally, and sometimes air is added for better visualization. Bowel preparation is required, and the colon must be cleared of stool. Post-procedure care focuses on preventing constipation from retained contrast. Monitoring for abdominal pain or failure to pass contrast is important. Computed tomography of the abdomen provides sectional imaging to identify tumors, abscesses, trauma, inflammation, and bleeding. Patients may receive oral or intravenous contrast. Screening for iodine or contrast allergy is critical. The test is quick but requires the patient to remain still. LPNs should monitor for contrast reactions such as rash, dyspnea, or hypotension. Virtual colonoscopy, also called computed tomography colonography, is a non-invasive method to detect polyps. It does not allow biopsy. Air is insufflated into the colon for visualization. Hydration after the procedure is encouraged if contrast is used. Magnetic resonance imaging provides detailed soft tissue imaging without radiation exposure. Patients must remove all metal objects and remain motionless. Screening for implanted devices is critical. Claustrophobic patients may require anti-anxiety medication. Ultrasound imaging uses high-frequency sound waves to produce images. It is commonly used to evaluate gallstones, liver abnormalities, cysts, and masses. Patients are often kept nothing by mouth prior to abdominal ultrasound to reduce gas interference. Nuclear imaging scans, such as the hepatobiliary immunodiacetic acid scan, aka hepatobiliary scintigraphy, is a gallbladder scan to evaluate bile flow and can help diagnose cholecystitis. Only small amounts of radioactive tracer are used. Gastrointestinal bleeding scans detect active bleeding using tagged red blood cells. The tracer remains visible for several hours. Endoscopic procedures provide direct visualization. Esophagogastroduodenoscopy, EGD, evaluates the esophagus, stomach, and duodenum. Patients receive sedation and require monitoring afterward until the gag reflex returns. Signs of perforation such as severe pain, fever, or tachycardia must be reported immediately. Endoscopic retrograde cholangiopancreatography, ERCP, combines endoscopy and fluoroscopy to examine the biliary and pancreatic ducts. It can remove stones or place stents. Post-procedure monitoring includes observing for pancreatitis, abdominal pain, and elevated temperature. Flexible sigmoidoscopy and colonoscopy allow visualization of the colon. Colonoscopy allows biopsy and polyp removal. Bowel preparation is essential. Afterward, monitor for bleeding, abdominal distension, fever, or signs of perforation. Ambulatory pH monitoring measures acid reflux over 24 hours. A thin probe is inserted transnasally or a wireless capsule is attached during endoscopy. Patients record symptoms and meals. Liver biopsy involves insertion of a needle into the liver to obtain tissue. Patients must be monitored closely for bleeding. After biopsy, positioning on the right side helps reduce hemorrhage risk. Vital signs are monitored frequently, and patients should avoid heavy lifting or straining for several days. Laboratory testing plays a major role in diagnosing gastrointestinal and liver disorders. These tests help identify bleeding, infection, inflammation, liver dysfunction, biliary obstruction, and clotting abnormalities. As LPNs, understanding what each test measures and associated nursing implications is essential for safe patient care. Fecal testing includes stool examination, guaiac fecal occult blood testing, immunochemical fecal occult blood testing, and stool culture. A stool analysis evaluates color, consistency, odor, and the presence of mucus, fat, blood, or parasites. Occult blood tests detect hidden blood in stool and are commonly used as a screening tool for colon cancer. The guaiac-based test requires dietary restrictions such as avoiding red meat for several days prior to testing to prevent false positive results. Immunochemical fecal occult blood testing does not require dietary restriction and is more specific for human hemoglobin. Stool cultures identify bacterial, viral, fungal, or parasitic infections. Specimens must be collected in a clean container and sent promptly to the laboratory to prevent bacterial overgrowth or degradation. Serum bilirubin testing evaluates liver function and bile metabolism. Elevated bilirubin levels may indicate liver disease, bile duct obstruction, or hemolysis. Jaundice typically becomes clinically apparent when bilirubin levels rise above approximately 2 to 3 milligrams per deciliter. Specimens should be protected from light to prevent degradation. Some laboratories require fasting prior to testing. Alanine aminotransferase and aspartate aminotransferase are liver enzymes released into the bloodstream when hepatocytes are damaged. Alanine aminotransferase is more specific to liver injury, while aspartate aminotransferase is also found in cardiac and skeletal muscle. Elevations may indicate hepatitis, cirrhosis, or toxic injury. Hemolysis can falsely elevate aspartate aminotransferase levels. Intramuscular injections may also influence levels. Alkaline phosphatase is associated with biliary function. Alkaline phosphatase is elevated in biliary obstruction, liver disease, and bone disorders. Ammonia levels are measured to assess severe liver dysfunction and hepatic encephalopathy. Elevated ammonia can cause confusion, altered level of consciousness, and neurologic symptoms. Specimens often require special handling and rapid processing to ensure accuracy. Total protein and albumin reflect the liver's synthetic function and overall nutritional status. Low albumin levels may indicate chronic liver disease, malnutrition, or protein loss. Albumin helps maintain oncotic pressure. Decreased levels can contribute to edema and ascites. Prothrombin time, PT, and International Normalized Ratio, INR, evaluate clotting function and depend on adequate vitamin K and liver synthesis of clotting factors. Prolonged prothrombin time may indicate liver disease or vitamin K deficiency. International Normalized Ratio is also used to monitor anticoagulant therapy. Partial thromboplastin time and activated partial thromboplastin time evaluate intrinsic clotting pathways and are used to monitor heparin therapy. When drawing these labs in patients receiving anticoagulants, timing and proper technique are critical. The Helicobacter/Heal Helicobacter pylori antibody test detects antibodies to H. pylori, a bacterium associated with peptic ulcer disease and gastritis. A blood sample is obtained. However, antibody testing cannot distinguish between current and past infection. Other tests such as urea breath testing or stool antigen testing may be used to confirm active infection. For all laboratory tests, nurses must verify orders, explain procedures, ensure proper specimen handling, and monitor for bleeding after venipuncture when indicated. Understanding these values allows early recognition of complications such as hepatic failure, biliary obstruction, gastrointestinal bleeding, and clotting abnormalities. Nursing management of gastrointestinal disorders begins with application of the nursing process. Assessment is the foundation. A thorough history provides critical information about risk factors, symptom patterns, and potential complications. When obtaining a history, ask about weight changes, appetite, chewing and swallowing difficulties, bowel patterns, abdominal pain, nausea, vomiting, reflux, alcohol use, medication use, and dietary habits. Family history is important, especially for colon cancer, inflammatory bowel disease, or gallbladder disease. Exposure to toxins, history of blood transfusions, tattoos, recreational drug use, and sexual history are relevant when assessing liver disease risk. Because the liver performs many metabolic and clotting functions, patients with liver disease require assessment of multiple body systems. Look for bruising, bleeding tendencies, confusion, edema, jaundice, and changes in urine or stool color. Always verify immunization status for hepatitis A and hepatitis B. Physical assessment begins with inspection. Examine the teeth, gums, and oral mucosa because digestion starts in the mouth. Inspect the skin and sclera for jaundice or discoloration. Observe the abdomen for contour, distension, visible veins, scars, or hernias. Marked abdominal distension with taut, shiny skin may indicate ascites. Assess for edema in the lower extremities. Auscultation of bowel sounds is performed before palpation because touching the abdomen can stimulate peristalsis and alter findings. Bowel sounds are typically heard as soft gurgles every 5 to 15 seconds. Normal frequency ranges from approximately 5 to 30 sounds per minute. Hyperactive sounds may indicate diarrhea or early obstruction. Hypoactive or absent sounds may occur with ileus or late obstruction. To confirm absent bowel sounds, listen in each quadrant for 5 full minutes. Although bowel sound auscultation is routine, research suggests it does not perfectly correlate with actual peristalsis. However, it remains a standard component of assessment and may guide further testing. Palpation should be performed gently at first to identify tenderness or masses. Watch the patient's facial expressions for signs of discomfort. If a pulsating mass is present, do not palpate deeply because this may indicate an abdominal aortic aneurysm. Assessment for ascites includes observing for bulging flanks and measuring abdominal girth consistently at the same anatomical landmarks. Accurate measurement and documentation are important for monitoring disease progression. Laboratory and diagnostic test results must be reviewed. Dark tea-colored urine may indicate bilirubin presence. Clay-colored stools suggest lack of bile flow. Fatty stools that float may indicate malabsorption. If vomiting occurs, assess for blood or coffee ground appearance, which may indicate upper gastrointestinal bleeding. Focused assessment includes inspecting the anus for hemorrhoids, assessing swallowing ability, and evaluating stool and vomitous characteristics. These findings guide nursing interventions and provider notification. Anorexia is defined as a loss or absence of appetite. Physical causes include poorly fitting dentures, oral infections such as stomatitis, decaying teeth, halitosis, altered taste sensation, nausea, gastrointestinal irritation, or chronic disease. Psychological factors also strongly influence appetite. The sight, smell, and memory of food stimulate appetite, while anxiety, fear, anger, depression, and unpleasant environments can suppress it. Social isolation and institutional meal settings may further reduce intake. Persistent anorexia must be addressed because prolonged inadequate intake leads to weight loss, protein depletion, electrolyte imbalance, and delayed healing. Nursing interventions include performing mouth care before meals, monitoring laboratory values such as albumin and electrolytes, documenting percentage of meals consumed, and identifying cultural or psychosocial influences. For older adults, diminished taste and smell, polypharmacy, dental problems, and depression are common contributors. Encouraging preferred foods when appropriate, providing companionship during meals, and assessing for depression are critical. Nausea and vomiting interfere with nutrition and fluid balance. Causes include infection, medication side effects, anesthesia, stress, cancer therapy, and pain. Persistent nausea requires antiemetics and possibly intravenous fluids. Strong odors can exacerbate nausea, so minimizing scented products in the environment is important. Complementary therapies such as ginger may help mild nausea, but caution is required in patients on anticoagulants due to ginger's antiplatelet effects. Accumulation of flatus or gas occurs when peristalsis is slowed or when obstruction prevents normal passage of intestinal contents. Gas forms from digestive activity and bacterial fermentation. Patients may experience bloating and abdominal distension. Ambulation is often helpful to stimulate peristalsis. Position changes, mild Trendelenburg positioning if permitted, and application of warmth may relieve discomfort. Simethicone may be administered if the patient is not nothing by mouth. Constipation presents with hard, dry stool and difficulty passing stool. Contributing factors include low fiber intake, inadequate fluids, inactivity, ignoring the urge to defecate, stress, neurologic conditions, and opioid medications. Assessment includes hypoactive bowel sounds, abdominal firmness, and discomfort. Management begins with identifying the cause. Increasing dietary fiber gradually, encouraging adequate hydration unless contraindicated, promoting exercise, and reinforcing prompt response to the gastrocolic reflex are first-line measures. Pharmacologic interventions may include stool softeners, bulk-forming agents, or medications specifically approved for opioid-induced constipation, such as methyl naltrexone, naloxegol, lubiprostone, or naldomidine. Fecal impactio N may require digital removal after lubrication and possibly administration of an oil retention enema. Pre-procedure analgesia may reduce discomfort. Maintaining patient dignity and explaining the procedure are essential. Hydration plays a key role in bowel health. Recommended total daily water intake includes fluids and moisture from food. Patients should increase intake during heat exposure or increased activity. Counsel patients to incorporate fruits, vegetables, whole grains, and bran into the diet. Fruit juices containing fructose may act as natural laxatives. Diarrhea is characterized by frequent passage of liquid or semi-liquid stool. Causes include infection, inflammation, food poisoning, stress, and medication effects. Persistent diarrhea leads to fluid and electrolyte imbalance. Management includes monitoring intake and output, administering antidiarrheal medications as prescribed, encouraging oral rehydration solutions, and advancing the diet gradually as tolerated. Avoid caffeine because it increases peristalsis. In infectious diarrhea, stool cultures may be necessary. Contact precautions are implemented when indicated. Antibiotic-associated diarrhea may lead to Clostridioides difficile infection, which requires specific isolation measures and treatment. Probiotics may help restore normal intestinal flora when used with rehydration therapy. Perianal skin protection is a priority in diarrhea and incontinence. Frequent cleansing, application of barrier ointments, and warm sitz baths may relieve discomfort. Monitoring for signs of dehydration, such as decreased skin turgor, thick oral secretions, and reduced urine output, is essential. Bowel training may be necessary for patients with incontinence due to neurologic injury or prolonged immobility. Scheduled toileting 20 to 40 minutes after meals uses the gastrocolic reflex to stimulate defecation. Digital stimulation may be performed carefully when ordered. Consistency, privacy, and patient reassurance are vital. Safety measures should always be emphasized.